Max, I will to speak to them. RSBY beckons the private sector to discover the fortune line at the bottom of the pyramid. It's no CSR. It is the fortune line at the bottom. Look at the business, because that's a sustainable model. CSR, to my mind, is not. If you find business in what I say, let's have a dialogue. Let's move forward. Thank you very much. I would like to thank Mr. Gupta for having given me this opportunity to interact with practitioners. I love it. I love it. Thank you very much. And I will
I have just a comment actually. I was sharing this with him during tea time. 6 years back when he conceived this scheme and he presented to CII as an executive member under the chairmanship of Dr. Reddy, and at that time I told him, it's very good, very nice, congratulations, but I am skeptical of its implementation completion. I congratulate that you have proved me wrong and you have achieved much more than what was really expected. The two people I really share, I respect. One is Dr. Amarjit Singh, who become personal friend, being going around to Gujarat, where he launched a Chiranjeevi scheme for safe motherhood, doing delivery in public-private partnership. It's a success story, and this is the second one. I compliment you, sir. Thank you.
Thank you very much. Thanks a lot. I must share with you one of my experiences when I had gone to make this presentation before the World Line. The Rockefeller Foundation and Bill Gates Foundation, they invited me for a similar presentation. And after the presentation, during the tea break, one of their representatives asked me, Mr. Swaroop, you are a bureaucrat. What are you getting out of all this? Why are you doing this? You are so passionate about this scheme, very unlike a bureaucrat. What exactly are you getting out of it? I didn't have an immediate answer, but I asked him a counter question. I asked him that you foundations give billions of dollars to poor countries. What are you getting out of it? You just give me this money. So Pat gave the answer. They said, no, it's our job. We derive a lot of satisfaction and all the good wishes of these poor people come back to us. I got my answer. I told him I'm better off than you. I don't spend a single penny from my pocket. World Bank has paid for this travel here. They kept me in a good hotel. I'm talking to you. All this because of the scheme. All the good wishes of these people are coming back to me some way or the other. There's nothing else better than the motivation. And I must also share with you another very interesting. I have similar experiences. I went to a very small hospital. There was this old lady, 100 years old. She somehow got to know that I had something to do with the scheme. She called me Beta Idhar. All of you understand Hindi because the translation may not be that good. Beta Idhar. So I went to her. बोली बेटा मैं बहुत तकलीफ हूँ. हमने कहा नहीं माता जी आप ठीक हो जाएंगे. नहीं बेटा इन लोगों ने बड़ा ख्याल रखना था. These hospital वाले have looked after me very well. मैंने कहा नहीं माता जी ऊपर वाले की अनुकंपा से आप ठीक हो जाएंगे. नहीं बेटा अब तो मेरा समय आ गया. अब मैं ऊपर वाले के पास जा रही हूँ. वहाँ जाके एक बात जरूर कहूँगी कि तुम्हारी स्कीम बड़ी अच्छी. I tell you, I still get those things. What is a better reward than that? It's amazing. And that's what that drives the entire thing. And you know, in health insurance, it is only once in a blue moon that you come. But if this PTS comes, he's going to bless me even more. And it's going to come. I have absolutely no doubt about it. It's going to come. Any other question?
Yeah, I had a question. What were the challenges you faced?
Oh, enormous challenges. First, I'll tell you the challenges that I faced when we started it and challenges I faced today. When we started it, no one believed in this concept. No one believed that this could happen. No one believed that this whole idea of marketing will work. Because what we did was, we said that we will not issue orders from here. We will go and talk to the states and sell this product. So the initial challenge was penetrating the attitude of the bureaucracies and the politicians. And it was quite a challenge. That is one. Number two, when we started it, the data was terrible. You know, I didn't have it here. There is a slide that I normally use for showing it. I downloaded it from the website. It's Kanhaiya Lal. All the 5 dependents thereof are Kanhaiya Lals. All have the same age as 20 years. I don't know how did we do that. All the dependents. And the most interesting bit was that the relationship of the dependents to the head of the family was Sali, lucky man. It's 5 of them, but all 20 years. I don't know how did. So data was a huge challenge. Then third was to get the stakeholders on board. I remember the first time I addressed the insurance companies, half of them were yawning. They said, there's another harebrained idea from the government. Because in this, all the investment had to be made by the insurance companies. You know, I don't know whether I did it deliberately or accidentally, perhaps partly deliberately, partly accidentally, that I didn't want to do anything. I wanted someone else to do it for me. It has evolved that way. And the scheme has happened because I think those people are better off than I was. I didn't know in any case much, so we managed to get them. But to get them was very important and very difficult to get this. But the challenges that I face today, and technology was a huge challenge because smart card, everyone talked about smart card. I can share with you another instance. I remember that on the 12th of September 2007, I was asked that someone wants that this smart card should be launched by the top person. So I said, we're not ready. Now in government, you can't say when the top person says that it has to be launched, it has to be done. I was told in no uncertain terms, it has to be done. I said, I will not do it. It's a showdown. And as luck would have it, in another scheme, smart cards were actually distributed on that particular day in another scheme, not this. We refused and we didn't do it. Those were the last smart card issued under that scheme, thereafter they didn't issue. It's a different matter. That man is now creating a lot of problem for the government. He's elevated trade and he's creating trouble. But this scheme, we didn't do it that day. We started it in April next year and we sustained it. So, you know, the government functioning itself was the biggest challenge internally. But I must tell you, the amount of help and cooperation that I got from all that came to be associated, and of both the Almighty, it wouldn't have happened without that. Because see, the World Bank came to help us after this Wall Street Journal report. Suddenly everyone woke up. They immediately called me, what is this going on? They were trying to find an answer to health insurance. Probably they found an answer in this health insurance scheme, and then gradually everyone. Today the situation is, an officer, senior officer from the Ministry of Finance rang me up and asked me one day before the budget, how much do you want for this scheme? Music to my ears, 31 years of my service. We've already always pleaded with the finance minister to give me some money. Today they are asking me, how much do you want? That I think was very difficult journey that day. Now today we face four major challenges. Some of you can help me there. The first challenge is that despite its goodness, I'm unable to convey this message to the beneficiary that this is what the card means. He's damn thrilled with the card. He doesn't really know that he can get this benefit from the card. So we have engaged NGOs, poor estate accredited societies, UNICEF, all these agencies are helping us. The second is capacity building. Now hundreds of teams are going in the field. There are thousands of hospitals. All those guys have to be trained. How do you do that? That's a huge challenge we are trying to do. The third is the quality part, and that's where I require your assistance. You know, I tout numbers, we have 32 million, 110 million. What is the quality of service that is being delivered in the hospitals? So we have worked out certain quality parameters. People ask me that your hospitals are good for nothing. I mean, even in the newspaper, they're bad hospitals. Now what do I do? In some districts, there are no hospitals. So I have to take hospitals that are available. Now my strategy was that I'll get them sucked into the scheme, let them taste blood, and then I'll discipline them. Today I'm disciplining them. Today they want to be a part of the RSP because they're getting business out of it. And since they're getting business out of it, I can discipline them. It's happening. And fourth and foremost, which has derailed a large number of health insurance schemes, is the frauds that are happening in this scheme, collusive frauds. But fortunately, we have a technology or the systems that we have that since the data comes daily to the insurance company server, they can on a daily basis set through 50 triggers and see what is going wrong there. And perhaps this is the only scheme where we have de-empaneled 260 hospitals in the country. And they happen almost within 24 hours. The data comes, the team goes, catches them, and they are nailed. And as RSPY is gradually becoming a brand, at least in the rural areas, they don't want to be out of RSPY. They don't want this black mark that they have been banned from RSPY. But the journey is still on. It's still difficult. Yes, sir.
Your 30 rupees is the government collects, and the entire thing is subsidized by the government, as I understand today. Now, when you get into, let's say, self-sustaining mode, because this scheme, as you go along, more and more population will get covered, and at some point of time, the expenditure will just balloon. So, to make it self-sustaining, are you thinking of using this platform? Say, we're not talking to the healthcare insurance people, but for lower middle class people who can afford and provide the same type of coverage or better coverages on payment. So it becomes self-sustaining for people who cannot afford.
Absolutely correct. We are at it. Absolutely. That's the way forward. See, government, I'll explain this to you in the American context. The biggest health insurance company in the US sent a 5-member delegation here to understand what we are doing in RSP. So I still, as I said, I don't know too much, but I could understand the difference. In the US, and that will probably answer your question, you have a private individual, you have a private hospital, and you have a private insurance company. Who's the exploited person in this? The private individual. He's totally lost. Especially the poorer part, there is a serious problem there. And that is why, and I'm not trying to blame anybody, as a consequence of the escalation of procedure costs, the insurance prices are going up. And what is happening in the US is people are unable to afford this insurance, so they're getting out. So the number is coming down. When number comes down, what happens? The price goes up further. They got into a vicious circle. What has happened in India? The government has created a platform, and government bargains on behalf of these poor people. So we fix the procedure cost. Now we keep negotiating with the hospital, discussion with them, but there is a negotiated cost which the government negotiates on behalf of the poor people. So it helps in cost containment. Now I'll give you an example that there are private sector insurance companies, there are private groups who have their own insurance. And they came to me and I asked them, why do you want to join RSPO? They say that with half the premium I get the same benefit from RSPO. How does it happen? Because the administrative costs are already sunk in, the technology costs are already sunk in, everything is already there. You have to only write that platform, make use of it, to bring down the cost. Now some other countries are trying to experiment, creating a national platform through government intervention and allowing the private businesses to write that platform. I think that's the way forward. That is what public-private partnership is all about. If we expect the private sector to create that national platform, it is not possible. If we expect the government to deliver everything from that platform, it is not possible. So government does what it can do the best, create a national platform, create protocols, create processes, create procedures, create regulations, and allow the private businesses to ride on it. I think it's a win-win for everybody. One reason why RSPO is happening, because everyone perceives that he's winning. If any of the stakeholder perceives that he or she is losing, the scheme will collapse.
Now, with the extension to PDAs and other things, are you making UID redundant?
You're asking the wrong man. It's a very sensitive issue. Very, very sensitive issue. Our job is to make it happen. We do less of talking. We do less of promising. And one reason why probably we've been able to deliver and people appear to be satisfied is that we didn't promise much and we don't promise much either. We do humbly believe that there is this platform which can bring a lot of succor to the poorest of the poor in this country. This is a platform that has stabilized, can work and perhaps will work. Only posterity will decide which was a better platform.
I have a point. Being a telecom guy in the middle of doctors, so one is that this is dependent quite evidently on a smart card. Okay. Is there a line of thinking you have to extend it? The national telecom policy says this is going to be a device going forward. Won't just make you talk, but can do a lot more for us to reach. So is your department wanting to evaluate the feasibility of using a mobile to extend and scale up the scheme?
We are already doing it.
Wonderful.
We are already doing it in a limited context to begin with. I'll tell you why we are doing it. Again, correct me because I'm not technologically very sound. This is what they have told me. One is collection of data, the other is transmission of data. Now, internet availability, there is a limitation. So we are using mobile technology to transmit data from clinics. Hospitals by and large have it. But in OP care, we'll probably require this technology and we're using it. Maybe my wish is over a period of time, smart card should be expensive.
Exactly. So because
No, but it is exactly about 10 years down the line. Till 10 years, I'll tell you why. I didn't want to get into that debate, but I am getting into it. The reason is, in India, I travel intensively and extensively through interior areas and check the connectivity there. That's one job, because that's the prerequisite for any connectivity. Now, my problem is that my patient is sitting there in a clinic and he's waiting for his thumb impression to be verified from the backend data somewhere, somehow, anyhow. Now, once that gets stabilized, I have no problem with dispensing with smart card. Till such time, I have to have an offline system. Let me give you another example, and this will surprise you. We are assisting 3 German municipal corporations to use smart card technology as we are doing here for delivery of food subsidy. Why? I ask them, you are real-time connected. They say, Yes, we are connected, but we are not all the time as connected as we want to. This is Germany, mind you. And if you don't believe them, they're coming here in November to finalize the proposal. I was in Germany, talked to them, I was myself surprised. So whereas it is eminently desirable and probably possible, I don't know when. When it comes, I think smart card should be dispensed with. So smart card is not the lasting solution for this country. But this poor man cannot wait for that solution. I can't keep telling him that there is this phone, you can do it. It has its limitations. I am told it has its limitations. Once those limitations go, dispense with smart card, go only with phone. So this technology will come and probably is the answer to the future. But at this point in time, I have to make, I heard this 4 years ago when I started RSBI. We have moved. There's no doubt we have moved. But until this it gets demonstrated effectively in clear large numbers, I don't accept that. Theoretically what you say is absolutely correct. It makes sense to me also. Why are you necessarily making him carry a smart card when he can operate the mobile phone and everything can be done? Please demonstrate it on scale. Those that are talking of online systems, this is totally offline, online systems, I ask them, what is the number that you've tested with your backend data that makes you believe that it will work? I want that number. If I have collected 200 million data, have I tested 1 million data or even 100,000 data on a real-time basis to see whether it gets the data check from the backend and gets me here? They are not ATMs. I am talking of places like Nauna, Bhanjan, remote area in Tripura. And mind you, those guys beat me more than anybody else here in Delhi. No one knows about RSBI. Not many people would know about RSBI. I don't care less. The guy in the field knows it. You talk, these evaluations are talking to those people. When this Wall Street Journal team came to me, I said, you are talking to the wrong person. हिंदी में हमारे तरफ कहते हैं हलवाई से पूछेगा तो वो बताएगा जलेबी अच्छी है तो अच्छी बताएगा आप जाके पूछे जो खा रहा है जलेबी अच्छी नहीं they went to the field and talked to the beneficiaries and then they came back and published that the beneficiaries say this is the best thing that is happening. So whereas I totally agree with you on a theoretical front, on a technology front, I don't think India is today ready to launch it at a scale that I am talking. 110 million people being able to access the backend data on a real-time basis to get a benefit. He can't be standing in a queue of a PDF shop with his data still being transmitted and he waits. It's coming. And there's a whole queue of them. So let's be realistic about it, whereas theoretically you're absolutely correct and technologically also you may be correct, but practically, operationally, and that's why I'm talking to you, these people will know what happens in the hospital. When a patient comes, there is a rush there. Oh, wait on, I'm just trying to connect you to the backend server to see whether your tummy pressure matches. Will that do? There's an emergency there. It won't. But that's the way forward in the future.
Thanks, Councillor.
Yes, sir.
Sir, what is your experience with regard to these smart cards? Because these are being used by the poorest of poor, illiterate people. They tend to lose it. There is a card destroyed. I mean, what is your experience overall? Because it's a large quantity.
With you and me, the card can get lost. For him, it is the prized possession. I would like you to recall the first card that you got. It was the prizest of possession that I had. I found my identity that day. No one could take that card from me. For him, you can't believe how he keeps it. Sometimes they take it overload, and they have been cases where he found this classic identity. He went to his residence, he said, this is my identity, took a nail and hammered it on his door. It happens, but very rarest of rare cases. We haven't found lost. I was myself aghast that the cards are not getting lost. Why? Because unlike you and me, he has just one identity, one card. And imagine how prized is that possession for him. I was proved wrong. I thought exactly like you. How does this poor man? And I will ask this question. He has a dirty dhoti. Where will he keep it out? He rolls it, keeps it in a cloth, and because for him this is the only identity card he has. With the Ashoka emblem there, he has a clear identity. No.
Actually, we have Sam Tikroga waiting on the other line to connect with us. So what we'll do, I'm sure Ravi, no one is going to leave you. I have a lot of SMSs saying we want to talk to him within this meeting. So once we have Sam, because we're trying on the other side to get him for video conference, to interact with us, we'll have you to come again and address those questions. I was going to eat it to lunch, but we're going to have that. If you don't mind. Question is, Sam around 2 minutes. So Sam is going to, we can take a question, and as Sam comes, we'll stop by, and then after that we'll connect. Thank you.
So I'll serve you till such time. At your service.
Mrs. Ru, can I ask a question?
Please, you have only 2 minutes though.
Okay. What is the kind of data which is available with the insurance company at the back end? I mean, I want to know what does the chip contain, or how much data does it have?
The chip contains very limited data, but the back end has huge data regarding the procedures taken, the cost, the interventions, all is there. Whereas the front end chip doesn't contain any data. Chip contains only biometric data, his family data, his photograph. Now we've taken a decision to convert it into a health card, and a committee is going into, and again I'll look for your guidance as to what all data can be keep there, who all should be allowed access, what should be the access mode. But right now the card is an insurance card, not a health card. But back end we have all the data.
How does that get transmitted, or who writes the data?
See, I'll explain this to you. When a person goes to the hospital, he is diagnosed with some ailment. Now these ailments are pre-populated in a database. Now we'll have about 1500 procedures listed out. So the doctor picks up a procedure whichever he thinks fit. That procedure gets housed in the database. The procedure that they are adopting and the cost thereof. The other papers are retained by the hospital. The entire diagnostic data is not transmitted. It is used only if the insurance company raises a question, then they can go and look at the data. Otherwise, we don't check. I ask the insurance company, when you settle a claim, what is the data that you require? So they gave me a list of requirements. So we said, what all can be digitized? What all could be digitized has been digitized. Rest of it, if the insurance company wants, because insurance company is allocated a district, so they maintain an office in the district. So the officer of the insurance company, and it's a monopoly for that insurance company for that year in that district. So it becomes economically viable for them to set up that office. So he can go to any hospital, and they do go to the hospital and look at the papers. But he insists that the insurance company should not ask for papers. They have to go to the hospital and look at the papers. That's the difference between other insurance companies and insurance schemes and this. They do go to the hospital, they do undertake audit if they require the detail. And that is where the information analysis becomes important. They look at various figures, and only in select cases they go and look at the papers. It is still evolving, we are learning, and over a period of time it will get probably improved. Yes, ma'am.
First, I think we'd like to congratulate you. Tremendous traction, and any healthcare providers happy to see care going to the last mile in India. I wanted to understand a bit more about the plans on the primary healthcare.
What the decision is as follows. We did a couple of experimental projects, one in Odisha, the other in Gujarat, 2 extremes of the country, just to understand processes. Actually, in this scheme, the total focus is on processes. We believe that if the processes are okay, they end out to be okay. So, having learned how to use technology there, the decision now is as follows. We will allow the existing inpatient care hospitals to provide outpatient care, and we have defined 2 procedures. Now, right now it is pretty crude. One procedure is without diagnostics, which is 100 rupees. One is with diagnostics, which is 150 rupees. And we are trying to define what all diagnostics will be included in it. As simple as that. Now, this will be now universalized in the sense that next tender document, it will include 2 also as the procedures apart from the 500 inpatient care procedures. Then there are other sets of experiments that are going on, wherein the insurance companies will in parallel also standalone clinics. And this experiment on the lines of what happened in Puri and Mehsana is now going to happen in 3 districts in Punjab, 1 in Himachal Pradesh, 1 in Mizoram, and 1 in Hyderabad. And even as I talk to you, discussions are still on with some other states, because there the premium is likely to go up. Someone has to fend for that premium, and it's going to go up substantially. We are trying to find how that premium can come and how can that model become sustainable. But within the RSBY scheme, without extending the outreach of standalone OP care facilities, we will start with this, understand the behavior both of the hospital as well as the patient, and then probably go in for further expansion. That's how it is. My 2 minutes are over.
Let me check if
Technically, our 2 minutes are over. Your technique always lets you down.
Thus, you have to use appropriate technology.
Yeah. I can't tell that to Sam, unfortunately.
Please do. Why don't you tell him to that?
I don't
You should be the first person to know
We tried
that.
to actually set up video conferencing in Zoom, but I think Hotel had an issue with the bandwidth. They couldn't actually set that up.
There's no issue here, so I'm here.
This drawing room in
Yes.
Chicago, and it was fabulous. Sam has
The
exactly
reasons
the
why most of the private hospitals or the corporate hospitals are not daring to come on board in many of the insurance projects are. One is that the procedural delays that that is there in payments. You don't get paid, and the procedures are so cumbersome that it's very difficult to, other. And I think to a great extent you have tackled that issue. The other issue is the pricing. It is so low that it's very difficult for them to deliver the care. And then what happens is there is a disparity between a person who is paying 500 rupees and a person who is paying 100 rupees. Now you say that, say for example, 150 rupees with diagnostics and consultation, it becomes very, very difficult for any hospital to serve quality care. Now, arrive at these numbers. How do you arrive at these numbers, and what's the rationale, and how do you make it more realistic so that the scheme is okay?
See, when you use the term realistic, you look at it from your perspective. And when we look at realistic, we look at a larger perspective. We do not arrive at a number on our own. We have very intensive consultation across the board with the hospitals, including, I don't know which hospital are you from, including the bigger hospitals. And the logic is very simple. Wherever you keep the ceiling, everyone is going to charge that much. That's how it operates. So where do you keep the ceiling? The more you pick the ceiling up, the more premium will be there. So you have to arrive at a compromise number, and averages this is the problem. Now, how are some of the medium and slightly bigger hospitals participating? I asked them why they are participating, now they are. And their logic is very different, very economical. They say, we have sunk in this capital cost. If my marginal cost is less than the money that you pay, I'm with you. And a lot of them are with me because of that. Because that money is already spent. That is one. Number two, and I don't know whether I should be saying that here. We talk big about the poor people and serving them and have these conferences and all. We are not even prepared to sacrifice a penny for these poor people. What are we talking about? Some sacrifice has to come both ways. When I listen to this logic of cost not being good, and then we talk about poor, as seminars, workshops, it pains me. It pains me because you can, if you want, cross-subsidize. And when I say you can, because I know many people are doing it today. Some of the hospitals have come back to me and told me, and that gives me so much pleasure, They come back to me, sir, we were in any case serving these poor people, but now you have given me money to serve these poor people. It may not be the money that you would want, but there is some money available. Is it so bad enough for you to keep away? I don't think that is the cause. And I was mentioning to somebody here, these are apparently not so clean people, and probably my regular clientele will be actually affected if these people are seen walking in the corridors or in the beds. I'm sorry for provoking you. But do some introspection. I don't think there can be a debate on this. I'm not trying to test anybody, I'm not trying to challenge anybody, I'm only trying to request you. Please do some introspection. When we talk of service to the society, here is an instrumentality through which you can actually transparently serve the society, serve the poor. But I keep saying that it should not be CSR only. You have to have some business. But if I equate business with commerce, then I'm in trouble. Then RSPY cannot go there. So you have to see whether it meets your commercial interest. Probably it will not. It meets your business interest. Probably it will. It meets your conscience somewhere. It certainly will. So I leave it to your good judgment as to decide whether you think it is worthwhile participating in this journey called RSPY. Yes, sir.
Just sharing a thought. I was wondering, there's a lot of mention of PPP cooperation. And I was wondering whether, at the same time, there's a lot of sections of society below who are not at the lowest level of income group, who are slightly higher, but given the rising costs in hospitalization and treatment, are not able to afford the adequate premium which would help them to treat themselves for various medical conditions. I was wondering if the same scheme could also do a subsidized rate for those people.
I'm so glad you're saying what you're saying. I've been marketing that within the government hopefully as a scheme. You said it. You said it, and don't say it only here. Please make it a matter of discussion anywhere that you sit. I'm so glad you're helping my cause, you're helping those people's cause who may not technically be poor but require this assistance. I'm thankful to you. Please continue with this idea. Keep pushing it. I am a great believer that things don't happen overnight, but if I join hands with people like you, I think we'll make it happen. I have absolutely no doubt. Thank you. Yes, sir.
India is a very diverse country. So are there any learning from penetration of this from different states in the country?
Oh, tremendous, tremendous, amazing learnings. I mean, I would say, I'll give you a website address because we have everything transparent there. They are critical of the scheme. Please read that. It is www.rsdy, the Rashtriya Swasthya Bima Yojana, rsdy.gov.in. And quite a lot of learnings are there in the evaluations. And huge amount of learnings. In terms of, misconceptions that we have about poor, in terms of misconceptions we have about hospitals. Some of the hospitals have made us proud. Made us proud in terms of the service that they provide, in terms of the pride that they take in serving the poor, in terms of making money as well as taking the pride as well as serving the poor. The beauty of this scheme is that I wish the old man were alive, he would have loved it. It is actually fortune lying at the bottom of the pyramid, making things happen. Because when I read his book, I was evolving this scheme called RSD. He was then alive. And I thought that I would go and meet him once this scheme happens. Unfortunately, he is no more. Because, the learning is, first, the poor man is not shy of making some payments. It's a misnomer that he can't. He will if you provide him the service. The renewal rates are amazing in the scheme despite the fact we charge 30 rupees every year. Now, to you and me, 30 rupees may be small. I have seen people standing with 30 coins in his hand to get this card. An old man with 30 coins in his hand. He wants this scheme. And the renewal rates are amazing. So, if I do deliver service, he may not be able to pay a huge amount, but he's certainly prepared to pay. That is one. It's a huge learning from this. Number two learning from this is, there is so much scope for public-private partnership. There is so much goodwill. The scheme would not have happened but for the private sector. And I keep saying that, and I feel pained when some of the reports mention that private sector will not be able to deliver. Nonsense. We have to sit together, we have to talk together, we have to move together. It happens. RSBY demonstrates that private sector can play a positive role in delivery of services to the poor. And we will demonstrate it through PDS also. The PDS, my logic is, why are you keeping it only to ration shops? Give it to big bazaar. Why can't my poor man walk into a big bazaar? Imagine a scenario where a poor man walks into a big bazaar and gets a galla. It will happen in this country. So the private sector can and will participate. There are bad eggs in the government, there are bad eggs in the private sector. Why should we condemn each other? It's high time that the good people sat together. The bad people have sat together and, we are all very fond of scams. So everyone talks of scams. TV with that, scam. Every negativity you find everywhere. And the solution where we find, we say, we get a Lokpal and we get a solution. That's another nonsense going on there. When British left this country, they took justice with them and left laws behind. Laws and outlaws. So we feel law will be a solution to everything. No. So the learning of this scheme is we don't have a law in this. There's no law. There's no in-laws either. There's no outlaws. Just this scheme. And it's working. So that's another learning. You don't have to really have a law to make a scheme work. Huge learning from this scheme. And even when it goes to PDS, there's no law required. Why do you require? Technology can be a great friend. Are you ready? Is easy there? Please stop me as soon as the VIPs are. Okay. Please stay. Yes, sir.
Okay, I'm from Apollo, and we have something called the personal health record, which is online, and it has a unique healthcare identification number. Now, this can be populated with all the personal health details of any individual. And suppose it is linked with your card. The person who is online at least can access every healthcare of his own.
You don't have a copyright on that?
We have more than willing to share with you.
We love it. We are trying to move in that direction and we love to learn from you on that. What you've done, how we can learn and do it here. See, all the knowledge, all that has happened in RSBY has been people like you who in such workshops come across, we sit together and move ahead. Thank you very much for that offer. I'll take your business card and we move. Yes.
Thank you. I want to just inform that Sam has got into another meeting. Once he is out, he will join us, so we can continue with our routine session.
My routine is over, so
Great.
we are ready. Thank you very much. Thank you very much.
Thank you. Thank you, very insightful. I think a lot of us get enlightened with what you said. And if the world is following, we still don't know it's a shame for us. What we wanted to do now before Sam would join us, we of course know that there's a lunch. But before that, we also wanted to discuss. See, this is a starting point of a dialogue. What do we do in the next dialogue? This time we wanted to listen along. it was very clear that we want to listen to the policymakers, what they have to say. And what do we do subsequently? That's something, we need to have ideas from you as participants, from people on the other side, like how should we take this forward? What are the ideas to do that? So should we calculate this into a dialogue every 2 months, on specific topics? So like Dr. Shinam Reddy says, define the purpose. It's a partnership for a public purpose. So how do we take it ahead? So those ideas we need to discuss. It can't be just a dialogue at a day and stop it and end at that.
My suggestion would be that